Hi all, today we will be discussing immediate complete dentures. For a patient facing the loss of all natural teeth, he or she has to undergo the following treatment options. It includes get all the teeth extracted, wait for 6 to 8 weeks, followed by a conventional denture fabrication, or converting the existing partial denture into an interim complete denture, or make a conventional immediate complete denture. According to GPT-10, an immediate process is defined as any removable dental processes fabricated for placement immediately following the removal of natural tooth or teeth. And according to Hartwell, an immediate complete denture is a dental process constructed to replace the lost tooth and associated structure of maxillae and or mandible and inserted immediately following the removal of the remaining teeth. Classification of immediate complete denture. It can be classified into the conventional immediate denture and the interim immediate dentures. The conventional immediate denture or classic immediate denture is the one that is placed just after the extractions, and after healing is completed, the denture is refitted or relined to serve for a long time. While the interim ones, these are fixed or removable dental processes or maxillofacial processes designed to enhance the aesthetic stabilization and or function for a limited period of time, after which it has to be replaced by a definitive prosthesis. The requirements of an immediate complete denture includes, according to Hartwell, compatibility with the surrounding oral environment, restoration of masticatory efficiency, function in harmony with speech, respiration and deglutition, aesthetic acceptability, preservation of the tissues that remains. The advantages include maintenance of patient's appearance, act as a bandage or splint to control bleeding, less post-operative pain as extraction site is protected, vertical dimension, jaw relationship, muscle tone, face height and tongue position is maintained. Speech and chewing habits and digestive function are not compromised and nutrition is maintained. Adjustment to new dangers is more quicker. Patient social, professional, and psychological status is not hampered. Artificial teeth can be arranged in same position occupied by the natural teeth. Less resorption and better preservation of the residual ridge. So there are many advantages for the immediate complete dentures, and it's actually a fast replacement of the anterior tooths. The patient's appearance, psychological benefits, all those things, weightage, the disadvantages. So the disadvantage include the anterior train is not possible. It requires more chair side time and additional appointments may be required. And the cost is also another factor. Then it might require frequent relining as the bone will resorb right after the extraction. In the first 6 months, there is a little rapid rate of bone resorption. Even though with proper adaptation, there will be some amount of bone resorption that might happen under the immediate complete denture. So it might require frequent relining. Anterior training is not possible. The reason is that we are doing the anterior extraction on the same day of the denture insertion. Another disadvantage is that as the jaw relations are recorded with the natural teeth in varying number and location, inaccurate centric and vertical records are possible. It cannot restore the stimulation that was supplied to the bone by the natural teeth. That's in scenario with the all other dental processes that we give except for the FPDs. Diagnosis and treatment planning. The diagnostic procedures are maybe considered the patient examination and consultation interviews. The patient examination, we will try to include the findings of local and systemic status, radiographic studies, visual and digital examination, then accurately articulated diagnostic cost, then appraisal of any existing processes if present. Some of the local factors that we have to consider is that the condition of the teeth to be extracted, position of the teeth, presence of any foreign bodies, the presence of bony or hard tissue undercuts that has to be reduced or eliminated, exostosis, that is just bone outgrowth, then bone loss adjacent to the remaining teeth and muscle coordinations. This we have to consider because all these have some primary assessment or care that has to be given before proceeding with the actual treatment of the immediate complete denture. All these will come in the primary care that we will give, or the surgical procedure include in the first surgery of the immediate denture fabrication. Then comes the consultation interviews. In the consultation interview, we will just ask the patient history, mental attitudes, we will evaluate, and the existing systemic conditions we will, or medical history, we will evaluate. In the past dental history, we will check for the hemorrhagic tendencies, excessive swelling or excessive postoperative pain, allergic reaction to local anesthetics, and all those things. Just to the same history as that of extractions, as we are doing the extractions on the same day of denture delivery. The systemic conditions we might check for is that necrosis, osteoporosis, and xerostomia in patients with poorly controlled diabetes. We might found these conditions with diabetes. And in cardiovascular or cerebrovascular disease patient, there might be some poor clotting mechanism. And right after surgical menopause or anything, there will be mucosal disorders such as desquamatitis, stomatitis, etc. Then there could be collagen disorders and diseases of the nervous system. So all these things we have to evaluate. If all these things are seen or anything, we have to take special care for each medical conditions. Mental attitude, as we all know, the mental attitude includes the philosophic patients, the ecstatic patient, hysterical and indifferent patient. Of which the philosophic patients are the best candidates for immediate danger. Ecstatic patients can be made more favorable, and the hysterical and indifferent patients are least suitable. Then treatment planning, it includes almost 8 steps. First surgery, that is the surgery that is to correct the undercut or the tissue bed or the bone contours. That is the first surgery that we will do, or some posterior extraction or hopeless teeth or something we will do in the first surgery. Then after that, after proper healing, we'll go out with the primary impression and preparation of the custom tray. And after making the custom tray, we'll go out with the final impression. Then recording of maxillomandibular relation, train of the posterior teeth fully, preparation of a surgical template, second surgery and insertion, post-operative instructions and care, or the post-operative review. Okay, these are the things that we will see in the treatment plan or the steps. So the first step, that is the surgery, the surgical aspects that has to include the tissue bed, facilitating contours of the bone or soft tissues, that is removing any undercuts, any exostosis or tori has to be eliminated like that. Then comes the preliminary impressions. The objective of preliminary impression is to record the basal seat of the denture and adjacent anatomic landmarks. Type of the preliminary impression, a tray should be chosen that conforms reasonably well to the future denture bearing area. The tray may be metal or plastic, whichever. The border of the tray should be checked in relation to the functional sulcus, and we will use either alginate or the putty material for making an impression. For in case if there is a loose teeth, what we have to do is that we can either block out the loose teeth with soft wax so that there isn't any undercut on that particular tooth and the impression material comes out smoothly, or you can apply lubricating medium like Vaseline or anything over the tooth surface. Then custom trays, that is regarding the final impression. According to Bowser, we can use a single arch custom impression tray. The type 1 method more closely resembles a routine custom impression tray for removable partial denture. So the same can be used for a conventional immediate denture technique also. So what we do is that we usually block out the undercut areas and we will adapt the spacer by means of a modeling wax. A stop can be established, or tissue stops can be made by punching holes through the wax. The tray is outlined and then the tray is fabricated 2 to 3 mm short of the vestibular sulcus or roll, and to extend and include the posterior limit, that is a PPS region or the amular notch or the retromolar pad region. Then autopolymerizing resin is then just adapted onto the surfaces and according to the planned outline, and handle is placed in the anterior region. So for the easy removal, the tray is polished, tried in the patient. The 2 mm relief is confirmed in the patient mouth. Then border molding is accomplished and appropriate adhesive is added and final impression is made, usually with the light body elastomeric impression material. So you can see in the figure, it's a light body elastomeric impression material that has been done after border molding. Then type 2, that is in sectional custom tray impression. So in this 2 trays are used. Okay, and in this a posterior tray and an anterior tray compartment is there. So the process of fabrication is like this. Outline the borders of the tray, that is 2 to 3 mm short of the posterior limit and of the sulcus. Then adapt autopolymerizing resin or light cured resin to the posterior dentulous area, and this section of the tray should be just extending or covering onto the lingual surface of the teeth, slightly extending onto the incisal edges. That is the posterior part of the tray. Then anterior section is made. The anterior section, either it can be a stock tray or it can be a custom made one. The anterior section or impression material must cover the labial surface of the teeth and the vestibule. So it basically covers the labial surface and the anterior vestibule. The posterior sectional tray is seated in the patient's mouth, relieved. Border molding is done, adhesive is applied, and posterior impression is made. The posterior impression is then removed and inspected. Excess material is removed and is replaced in mouth. So the below figure shows the border molded and the impression that's made in the posterior aspect. Then it is placed in the mouth. The anterior section of the impression is then made. And the most important consideration here we have to do is that we have to carefully and properly reassemble the two separate components of the impression. And care must be taken not to distort this assembly during removal from mouth and during the pouring of impression. And once we get the cast after pouring the impression, it is trimmed. Then we go ahead with the maxillomandibular relationship. That is the fourth step. So here, the procedure for maxillomandibular relation record are identical to that of the complete denture. Undercut areas around the teeth are blocked out with wax. Then the denture base is fabricated and wax rims is made. Then remaining teeth and anatomical landmarks as retromolar point can serve as a guide to know the height of the rim. So this is how the rims are made. The record base and occlusal rims are tried in the patient's mouth and evaluation of the patient's existing vertical dimension is accomplished. The occlusal rims are trimmed to the desired vertical dimension. Protricts may be used to evaluate the vertical dimension. Afterwards, a phase 4 transfer is done and the new centric relation record is made and the mandibular cast is then mounted onto the articulator. Teeth selection and arrangement. We will set only the posterior teeth in centric occlusion as the existing natural teeth might be present in the patient's mouth. The trial denture bases are tried in the mouth and used to verify the vertical dimension of occlusion and centric relation record as with the complete denture. So once trial is done, immediate dentures cast must be modified according to the anticipated changes in the contour. So this is an important step. Here we will do periodontal probing around the alveolus in the patient. So for a normal situation, it will be around 1 to 2 mm. The alveolus will be 1 to 2 mm below the soft tissue margin. If the labial cortical plate is intact, the teeth are removed at the gingival crest level and few millimeters are then prepared to simulate the natural tooth removal. That is in the cast. The cast will just break off the teeth that is remaining and also slightly contour the occlusal surface or in the gingival crest area. We will just reduce it by 1 to 2 mm. If more pocketing is there, then deeper preparation of the cast has to be done. Then the labial aspect is also slightly contoured to simulate the soft tissue delay. One tooth is removed at a time with rotary instrument or sharp knife and smoothened with hand instrument. Then the adjacent tooth is being removed like that. Once a tooth is removed, we can actually replace with the new teeth so that the tooth can be maintained in the same position if the arch form is correct for that particular patient. Then is the construction of a surgical template. So surgical template comes around the sixth step. So surgical template is a thin, transparent foam duplicating the tissues surface of an immediate denture and is used as a guide for surgically shaping the alveolar process. That is, after contouring of the cast, after removal of the teeth on the cast, we'll adapt or make a surgical template. And according to Boucher, the surgical template should be transparent, 2 mm thick, to provide rigidity and uniform transparency and able to securely seated in the mouth. Template is fabricated by following procedure: make on irreversible impression of edentulous ridge after the cast has been removed, for the impression in stone. Then after the cast or working cast is made, make a clear resin template on this duplicate cast by one of the methods. Either we can vacuum form a thermoplastic resin sheet onto the cast or fabricate the template with a lightweight clear material by means of spring-on technique with a clear acrylic resin or by processing the template in clear heat cure acrylic resin after making a wax up of that particular dimension. Then afterwards, while this is being done, the processing and finishing for a complete denture is being done with the master cast or the cast in which we have done the mock placement of the teeth along with the posterior trial. This we will do the acrylizing procedure and we will finish and polish the denture. So the denture is ready, surgical template is ready. Now it's the surgery. So surgery and immediate denture incision. During the extraction of the remaining teeth, that is basically the anterior teeth, care should be taken to preserve the labial plate of the bone and usually bone trimming is done. So the bone trimming will be done if required only after placement of the surgical template. The surgical template is used as a guide to ensure that the prescribed bone trimming is done adequately. The template should fit and be in contact with all tissue surfaces. The inadequately trimmed areas planned for bone reduction will blanch from the pressure and will be seen through the clear template, which is made of a thermoplastic resin sheet or the clear acrylics. Then afterwards, suture may be placed wherever necessary. So after this, immediate dentures that has already been done is being disinfected prior to the placement and placed in the patient mouth. And the areas of pressure, if there is anything, we can check with the pressure indicating paste and can be corrected. When occlusal prematurity are verified, a quick occlusal correction is done to allow simultaneous bilateral contacts. If denture is found to be inadequately retentive, we can go ahead with use of a tissue conditioning liner, but it has to be monitored because we doesn't want any material to go into the extraction sites. So once it is done, we'll give some instruction to the patient. We will ask the patient to do cold packs for the first several hours after surgery. Patient is advised not to remove the immediate complete denture for 24 to 48 hours. And we ask the patient not to expectorate or do any smoking. Then after 24 hours, what we do is that we will recall the patient. We will check for the occlusion using an articulating paper. If there is any occlusal prematurity that is not, we will correct it. Then any ulceration from pressure, we will check with pressure indicating paste. We will identify that area again and we will reduce. Then tissue surface is again cleaned and patient is asked to gently use a mouthwash. Then after 48 hours, we have to recall or see the patient again and everything that has been done. That is occlusal evaluation and also the extension evaluation has to be done. And the patient is instructed to clean the denture and to use warm saline rinses. And after 1 week, we'll again recall the patient. The sutures, if placed, are removed. Occlusion is checked again. Tissue surface is evaluated with pressure indicating paste. If any complaints of soreness occurs, soft tissue should be examined for any irritation, that is presence of any nodules or any overextensions has to be checked. The tissue conditioner, if placed at insertion time or anything, has to be replaced. Then after 3 to 4 weeks, if there is any complaints, we have to readdress it. If there is any further change in the occlusion, we have to clinically remount and see and correct the occlusion. If the occlusion is more than there is a severe change in the occlusion, we have to do the clinical remount. If very severe, we have to do a refabrication. After 4 to 5 weeks of healing, dentures can be relined if necessary. Resilient linings has to be removed and this relinings has to be done every 4 to 6 weeks interval until healing is complete. And after 6 months, the denture should be completely relined or remade depending upon the situations. So this is about the immediate complete denture. Thank you.